Okay, so this is the first case. It's a man in his 70s, and the history is that at some point he had an incident. He had a right upper quadrant ultrasound, which found a mass, and we can see, um, he has no known liver disease or anything like that. So you can see he has this big mass, non-specific looking, right? It's T1 kind of hypointense, on T2 kind of slightly heterogeneous, but mostly hypointense. Um, this is sort of arterial phase. It's a little bit delayed, but you can see the mass kind of enhances heterogeneously. It doesn't have any specific pattern of enhancement. This is more delayed images, so you can see kind of, again, somewhat heterogeneous. And here's the restricted diffusion. So mass also has restricted diffusion. So anybody have any thoughts or?
Is it an adrenal mass, Victoria?
No, no. This was arising from the liver for sure. And about 7 years ago, a patient had a mass, and it was about a third of the size. I don't have the prior images, but um, I don't want to see the chat. There you go. So it is a slowly growing mass. Patient has no history of primary malignancy, no history of liver disease. And this definitely is arising from the liver. Okay, so there's nothing specific with this mass, right? All we know, it's a solid mass, and of course, malignancy is the first thing you're going to think about. It doesn't have anything specific to suggest any specific malignancy, but it also doesn't have any specific to suggest a definitely benign lesion. So for these cases, we send them for biopsy. So in this case, patient, this was also a growing mass, although slowly growing. So patient had a resection, and it came back as um, this entity. So this was a path-proven solitary fibrous tumor of the liver. They are rare mesenchymal neoplasms. They're quite unusual in liver. They are benign, but they have some malignant potential. And the current older patients, women have slightly higher predilection, and findings, patients present with very nonspecific findings, and then imaging features also are very nonspecific, kind of mildly hyperechoic on ultrasound, and then heterogeneous on both CT and MR. And then FNA is usually not going to give you some fibrous tissue without a specific diagnosis. Okay, any comments? Okay. All right, you guys got to help me out of here.
So we have seen a case. I was just about to try and pull it up where it was a hypo-intense mass, but similar enhancement characteristics, and turned out to be a solitary fibrous tumor. I'm going to see if I can pull up that case also.
Okay, great. That would be great. Okay. All right, so we'll move on to the next case. Okay, so this is a common entity, but not necessarily using common modality. This was a 16-year-old child with abdominal pain, and this is just an example of a perforated appendicitis on MRI. Not something that we see very often, but this was a very nice example. You can actually see that this is the beginning. This is a cecum. This is the beginning of appendix. You can see a large appendicolith sitting near the base, and then everything beyond it is dilated, filled with fluid, and then you can see there's foci of air, and actually you can see the foci of air kind of in the tip. There's disintegration of the appendix, a lot of fluid, and here it is on the axial. You can see that the appendix is fluid filled, hyperemic, and And you can see that right here, the there's disintegration, perforation of the wall. So this was a perforated appendicitis on MRI. And here it is on the axials also, sorry, on the axials. The same findings pretty much. You can see, again, dilated appendix, foci of air, and here's the air extending beyond the lumen. So this was a focus of perforation in this patient. And then a companion case to this patient is this patient. And again, we see a lot of inflammation. And this is also an example of perforated appendicitis. You can actually see this is the beginning of the appendix. It's kind of normal. And then it's just, here's a big appendicolith. And then everything beyond that is dilated. And you can see the appendix is just turned into like a just perforated abscess. And here it is on the axials. This was a slightly younger kid. So you can see here just an abscess. And you can see that those abscess actually eroded into the psoas, which is not very common. Here's this concomitant CT done a few days before. You can see that big appendicolith. Here's that proximal appendix, which is not as inflamed, but you can see that the tip distal to the appendicolith is just perforated and just replaced by an abscess with inflammation. Notice how you can't really see the the involvement of the psoas. Here's just side by side. You can see how much easier it is to see on MR, and partially it's because of the high soft tissue contrast resolution of MR compared to CT. So sometimes it's hard to see kind of like something that involves the muscle, especially if it's not yet well formed. Comments, questions?
A pretty florid case. Okay, Victoria, if you let me share my screen for just a second.
Okay.
So just a companion case since you showed that case. Can you all see my screen?
Yes.
Okay, so here's the mass in the liver. Like I said, it is hypointense on T2 weighted images. This is in and out of phase. This was a middle-aged woman. And this is pre-T1, early arterial phase, and then on the delayed phase. So well-defined mass. We really weren't sure what to call it at that time, but nothing on diffusion. So this turned out to be a solitary fibrous tumor of the liver.
Was it resected or did you? Was it?
It was resected.
Okay.
It was resected.
Yeah, I mean, I think once it gets to the size and appearance, it's it's almost like intellectual exercise trying to figure out what it is prospectively. But bottom line, you'll need to have some sort of biopsy or something.
And so an interesting part of the story, which I just checked, was this patient had multiple myeloma.
Oh boy.
And then we saw this thing. So, because we see a lot of cases of myeloma, and we see a lot of EMD in the liver. So I think that's probably what we read it out as. And so they treated with the chemotherapy, it didn't resolve. So then they went in and took it out.
That's very cool.
Yeah.
But is multiple myeloma, when it involves the liver or plasmacytoma, does it have this like imaging characteristics?
No, it does not. But it can basically look like anything. It can look like absolutely anything. We've typically not seen it be hypointense like this, but we see so many patients with EMD that, that's the natural thing that first came to mind. Now we'll be more careful in the future when we see something so hypointense to think of solitary fibrous tumor.
Oh, that will be another 15 years probably. Yeah, I think I have like two in my interesting case files from the past however many years.
Okay, I'm going to
All
stop
right.
share here.
Okay. Does anybody else have any cases?
Actually, can you hear me?
Yes.
Okay, sorry to interrupt. I just I'm on a breast month, so it's a little noisy in this room. I apologize for that, but I actually have probably a more subtle case of appendicitis on MRI
Oh, let's do
that I
it.
could share. And I also have a solitary fibrous tumor case as well.
Oh, wonderful. Let's go for it.
But yeah, I'd like to at least show. Let me just try some advanced sharing here. Here you go. Okay, sorry about that. Okay, so this patient, they had suspicion for appendicitis, and she's a young patient. She's actually a pregnant patient, and you can see here on this axial T2 sequence, the appendix is already a little dilated, fluid filled. See some subtle periappendiceal stranding and some appendiculis in the mid to distal portion. And the stranding really, and of course, here's the fetus. The stranding is much more appreciable if I pull out this sequence here. Once I saw this, I was like, well, I haven't called a lot of this, but if I don't call it now, then I don't know if I ever will.
It's pretty cool.
Yeah. So again, not as I don't know, flagrant as your example, but I thought it was just a good example of an earlier appendicitis on MRI in a pregnant patient.
No, it's a great example. So one of having fluid in the appendix on the MR is actually very, brings it to a very high suspicion of appendicitis. Something that somehow I could never reconcile it because it's not quite the same thing for CT, right? But for some reason for MR, there are several studies that show it's quite specific.
I see.
So, but this is more your case has like dilatation and inflammation and a cute little baby.
I was looking at this case and I was looking at the T1 bright area in the kind of fetal abdomen, but I just didn't even want to talk about it because I didn't know like what's normal and what's not. So I just steered away from all that.
I think sometimes we see T1 hyperintensity in the bowel.
Yeah.
Although I'm not sure this early. But
okay.
Cool case. And she's probably this is the second trimester, right?
Yeah.
So she's lucky because like if you have to have a surgery, second trimester is like the safest way to go.
Okay. And unfortunately, like I said, I actually didn't brush up on the history or anything, but it's not a subtle finding by any means. If you looked. Within the left. Yeah. Yeah.
Also, oh wow. It's a great,
and this was yeah, this is biopsy proven. I actually looked this up the other day, and I could show you the ultrasound biopsy pictures, but they don't really add information here. But yeah, I think they also did an MRI of this case too. But the biopsy, like it came out, the surgeons kind of just took it out because I don't know what order things happened, but this ended up being a solitary fibrous tumor as well.
That's pretty cool.
Yeah.
It's also quite heterogeneous, similar to the case that Kedar showed in my case.
Yeah, and like you said, I don't think anybody's hanging their hat on that just by imaging, obviously. Yeah.
Right. No, I don't think there's a way to do so.
Yeah. Okay.
Cool.
I'm gonna stop sharing.
Thank you.
Hey, Victoria.
Yes, sir.
Can I show a consult case?
Please.
For the participants. So
let's do it.
And this just came up today, so I'm really curious to see what everyone thinks. So this is a patient who in 2016 had a rectal cancer, and I'm just showing one image of that. And then he's had this taken out. He's had a neoadjuvant chemoradiation. And then he comes back with, he's been followed up. So this is a scan from 2018. And on the arterial phase, we see these two tiny lesions in the liver, um, which kind of persist in the portal venous and then go away. This is 2018. This is January 2020. So they have grown larger, slightly larger, same enhancement characteristics. And this is, so he had multiple MRs in the middle, but the MRs have somehow always missed catching, because it's right at the dome and breathing and so on. So this is a recent MRI that he had with EOVIST, and these lesions have become even larger. And this is a 5-minute post-EOVIST scan. You can see there is a little bit of a, rim. And here is the 20-minute delayed scan. And I think there is still a little bit of a rim that you can see. So the question and those are the lesions that you are seeing on the haste sequence. So the surgeon's question was, what do we think it is? So I want to see what everyone thinks and what you think, Victoria.
So I have thoughts, but I'll let others speak. Okay, then I'll just speak. I think these are hemangiomas. I think that the size difference may be because of the timing. Like, look, the timing in the um, on the two phase, on two arterial phase is different. And if you compare, like, look at the hepatobiliary phase, right? That size looks very similar to 2018. So I would just repeat it with extracellular contrast agent, and then
So he's had 2 scans with extracellular contrast agents.
Okay.
And they've missed them because of the location. So my question to you was, do you think these could be FNHs? Because they have this peripheral uptake,
I think this is more likely just like the parenchyma that's a little compressed. Do you have DWI?
No, these are outside scans, so there was no DWI done on any of them. So I actually told the surgeon that we probably should do a follow-up one in our institute with DWI.
Yeah,
to see, because they didn't even look that bright on the T2-weighted images. So
it's not. It's possible that they're FNHs. I would.
But benign, right? Basically benign.
Yeah. But I would probably favor small hemangiomas.
Okay.
But
so we should get a follow-up on. We will get a follow-up on this. In fact, he was thinking of doing a laparoscopic biopsy.
No, I think that's plan. Way too aggressive.
Yeah. So I told him that I think it's benign and we can just follow it up. So.
But I would recommend getting. You're not. Let's say that these are FNHs. You're not losing anything by following them up with. With extracellular agent.
Yes.
You'll see the size, and then you'll know definitively these are not hemangiomas. I mean, it's a philosophical question whether or not.
Yeah, no, I just wanted to get an opinion. Basically, just wanted to make sure everybody thought it was benign.
Yeah. I agree. I think it's. Yeah.
Okay.
Totally
perfect.
Agree.
Thank you.
When you get a follow-up, will you let us know?
Definitely. Definitely.
Right. Okay. Anybody else? All right. I'll bore you with some more of my cases. Okay, so the next 3 cases are kind of the same theme. So also not a subtle finding, but you can see that there are these, kind of lobulated, somewhat heterogeneous masses in the adrenals. And then if I show you the coronal, you'll see that there are masses in the lungs as well. So, thoughts as to what the primary may be? So, with this appearance, obviously we're thinking malignancy, right? There's some lymph nodes here on the coronal. So, with this appearance, maybe some sort of widespread metastases. So we biopsied these, and this ended up being lymphoma. And the reason why it's interesting because lymphomas tend to be quite homogeneous unless they're treated. So this was not a very usual appearance of lymphoma in the sense that it's very heterogeneous. And if you go, and these also were lymphoma. And so all of his lymphoma is slightly unusual in the sense that it's a little more heterogeneous than usual. But this is lymphoma. And lymphoma in adrenals is not that common, but this is what it was. And then a companion case of another unusual location of lymphoma. And in this woman, it was a path proven ovarian lymphoma. And again, you can see very similar appearance of like kind of heterogeneous, slightly heterogeneous lobulated mass. Here it is on the coronals. You can see kind of lobulated again. So obviously looks not benign, so it would have to come out. Notice that there's really not much in terms of lymphadenopathy anywhere. So this was an kind of unexpected diagnosis in this case. Notice that there's no ascites, which is not typical for, like if you have a primary ovarian cancer with this size, usually there's going to be some ascites in this case that weren't. So that was just a ovarian lymphoma. Any comments? Any thoughts?
It's not common at all, right, Victoria?
No. So these like ovarian lymphomas, adrenal lymphomas are really, really uncommon. And again, I can't tell you if they tend to be more heterogeneous than than lymphomas. I just don't. I just don't know if there's enough known about these to say definitively that they tend to be more heterogeneous. I haven't read anything about that. So, but these two cases of unusual locations is quite heterogeneous for lymphoma. And this is a third companion case, and this is a more common appearance. So this is an example of small bowel lymphoma, and this is that
Aneurysm.
almost like aneurysmal dilatation. You can see that here's on the coronals. You can see that the mass is very large, right? And encompassing the wall, the entire wall, circumference of the, but there's no narrowing of the lumen, and that's because the lymphoma is A, soft, and B, as it involves the wall of the bowel, it knocks out the the von Meyenberg complexes, right? The neural network, and it so there's no peristalsis in this region, and the bowel becomes dilated. So it's like an unusual appearance in that a mass of the size you would expect to narrow the lumen, but this is one of the things lymphoma does. It does not narrow the lumen, but instead the lumen either stays normal caliber or even dilates, in which case we'll call it aneurysmal dilatation. Any comments? Okay, so the next patient, I don't remember the history, but here's, just look at the common bile duct and notice that the duct is dilated, and then you have like these mural masses right there. See that? Right there.
Yes.
Causing quite a bit of dilatation. Similar, you have kind of these mural thickening in the gallbladder as well. I'll show you coronal just one second. And you can see the same thing on coronals. You can see just kind of irregular mass, and it's not the typical cholangio appearance, right? And that cholangio tends to again narrow the, cause like this apple core appearance, and do the circumferential thing with narrowing and causing the kind of rat's tail appearance. So this is not
Is this like
necessary.
IgG4 disease?
That's a good thought, but this is an actual mass. See that? And it's enhancing there. Um, right? But I mean, I assume that IgG4 in some patients could do this. More typically, it mimics like a PSC picture, but I can't see why it couldn't do this. Anyway, but these were biopsied, and these are IPMNs of the common bile duct, and there were some foci of invasive carcinoma, and similarly, this was also. So, patient had a transplant after this, so the entire thing came out. So, so all of these were IPMNs with several foci of invasive carcinoma. So this was just a very unusual. There you can see that these masses do restrict. You can see that. So you can see some restriction going into the ducts as well. Okay.
Great case.
Say it again.
Great case, I said.
Oh, thanks. All right. So I couldn't open up like more than this at the time because I didn't want to crash the computer and then I would lose the recording. But I have more cases. Does anybody else have anything to share? Okay, then I'll just keep going. 2012. So, okay, let's just see. Okay, so this is an interesting patient, or interesting finding. As we go down, notice that the left kidney is not where it's supposed to be. And as we go down, there are two kidneys on the right-hand side. You can see that. And done. So any thoughts? And there's another finding here. Another anatomic variant. Does anybody see it?
Is there a duplicated IVC or?
Yeah. So there's duplicated IVC. You can see 3 vessels here. And then so you can see that both kidneys are on the same side. So it has a name here. So there's one kidney and there's another kidney. Does anybody know what the name for this? This particular is very uncommon. But anybody has any thoughts? So again, you see right kidney where it's supposed to be, and left kidney is.
Is it like a syndrome, Victoria?
No. It just has a name. I mean, it's like. So this is called cross unfused ectopia. So cross fused ectopia would be if the two kidneys were fused, and we've seen, but this is the only case where I've seen it's a cross unfused ectopia. So the left kidney is located on the right, but you can see clearly there's a space between the two kidneys, and so they're not fused, but the kidney is relocated where on the other side. And since things tend to go awry together, here's a nice example of duplicated IVC where you can see that the left-sided IVC goes straight into the renal vein, and it's cute. Okay, so this is I don't, this is an older case, so I don't remember the history, but here's the finding is in the abdomen. Where's our friend, the abdomen? Here you go. So what do you guys think? Kedar, I'm just gonna pick on you since I know
Could
you.
this be graft versus host disease?
No. No, honestly, I don't remember okay, I'm not gonna lie, I don't remember the history, but knowing what the diagnosis is, I'm gonna say no. So how about the findings?
The small bowel appears abnormal.
So here's the small bowel, right? But these are not small bowel loops. I know that they look like it,
Are
but
those
they're not.
lymph nodes of some sort, or?
Those are lymph nodes,
Yeah. So,
but they're not normal lymph nodes, right? They're
yeah.
necrotic lymph nodes, and you can see one here. So this
Was this
was,
TB?
yeah, this was TB. Cool, no?
Yeah.
This was path-proven TB. Notice that the lungs are clear. Go figure.
That's crazy.
The lungs are completely normal. So all of it was, but this, they sampled the thing, and it was, AFP positive, and the patient was, yeah. So anyway, so he or she, I don't remember who it was. The patient was treated for TB, for presumed TB. Okay, it's pretty cool, no? But I know, right? So like on the axial, as you scroll up and down, it looks like you're looking at small bowel loops connecting to each other, but they're not. They are necrotic lymph nodes.
They're mainly mesenteric, right? That's the only main site it looks like.
Yeah. So
They're not even retroperitoneal. So that's even more unusual.
yeah. So there was something here, which looks like in the liver, maybe even. Right. So it was a very unusual case because, yeah. All right.
Is it
So
Mycobacterium tuberculosis or some other mycobacteria?
they presumed it to be tuberculosis, but in truth, the path had positive AFP, so theoretically it could have been,
Like,
atypical.
or bovis?
Yeah.
I think
But
they are
they
more common.
right, but they presumed it to be. They just treated with whatever they. Okay, so
Okay.
a case with two-part finding. I don't remember the. This was a young person, 23-year-old person, and this is the outside study. So, any thoughts?
Yeah, choledochal cyst with
Local cyst.
Right. So
probably
this.
some mass.
Say it again.
Choledochal cyst with probably cholangio in that area.
Yeah. So this was a young woman or man. Actually, I'm not sure if it's a woman or man. But they have, type 4 choledochal cyst, right? Because both, intrahepatic and extrahepatic bile duct is affected, or biliary tree is affected. And you can see that there's a mass. And this is the complication of the, of the choledochal cyst that, we always kind of worry about. These patients are at risk. And you can see this thing is enhancing. So this was a path-proven cholangio in type 4 choledochal cyst. Okay. Any thoughts? Any comments?
So if you did a EOVIST scan, would it would we see the choledochal cysts, say type 5? Do you have any experience with that?
You mean Corolli's?
Yeah, for Caroli's.
I actually don't. I think I had like one clinical case of Corolli in my life, and that was not with EOVIST.
Okay, because we had one case and we did that, and at 20 minutes, nothing happened. And, it was an outpatient, so we really didn't know that we were scanning for Carolis, or we would have probably done a delayed and seen if. So we did a literature search, and there's a very mixed opinion, which is the reason why I was asking you, do you know of what
I,
happened?
I, okay, so this is totally like, I'm making it up almost, but I think that from what I remember about Carolis is that cyst may not. I remember that at some point we were taught that the Caroli is not really a choledochal cyst. It's a different beast in of itself, and so my initial thought is you would in Caroli you would not expect Evis to feel the
Okay.
but it's totally conjecture on my part. All right, so the next case is also a young person. She is 25. And she has hematuria. So you can see that you have this kind of mass-like appearance of her kind of right aspect of the urinary bladder, right? And then you can see that there's kind of feeling defect. Now, with all of that, there's no really obstruction to the flow of urine. So any thoughts? So, obviously, like whenever we see something like this, we think about TCC, even though she's 25, really not a good, not a good demographics for that. But, that being said, with this appearance, you have to think about it. One thing that kind of doesn't go well for TCC is, usually TCCs in this, in this location often, knock out the ureter, so that didn't happen.
Is it endometriosis of some sort?
Yeah, that was, so we said we need a biopsy, but with, with all this, we thought maybe it's, given her age and given that it didn't obstruct the ureter, we thought maybe this is more likely to be non-malignant, something like endometriosis. But of course, with this appearance, you must biopsy. So we did, and it did come back as like ulcerated urothelium with like stuff, and altogether was endometriotic implant with like ulceration of urothelium in this region. That's pretty cool. Let's just see. So this is a patient, was inpatient, came in with this finding. Kind of, you can see that the right kidney is just totally obstructed, and you can see multiple masses, along the dilated ureter, and then there was a mass kind of and a calculus distally. And so, and I remember this, but there was a subcapsular hematoma, as you can see here. But the main thing, you see these multiple urothelial masses. I'll show you the coronal, and here's the delays. Not very helpful, right? Because the kidney doesn't really excrete at this point. But there it is on coronal. You can see, again, dilated ureter with these multiple masses. And here's the distally, you have just obstructing mass with a calcification, probably just a calculus trapped in there. So, any thoughts? Come on, Kedar, help me out of here. Okay. So, so when we see something like this, right? So multiple urothelial masses, of course, we're going to start thinking some sort of multifocal TCC, which of course happens. So this was our primary kind of thought that we're dealing with multifocal TCC. And then if you look here in the patient, you can see that the patient also had a primary lung cancer. and then just massive mediastinal lymphadenopathy. So, and then I think, if I remember correctly, there was a study. No, I guess not. I thought there was a study that showed that this was a relatively rapidly developing problem, but I think I'm wrong. Anyway, so this was biopsied, this, and these, all of these things are Mets from the small cell lung cancer.
Wow.
Right. So obviously urothelial Mets are very, very uncommon. And so we didn't, but that's what it was. So we ended up biopsying it. And that's what it was. Just multiple. Actually, I'm pretty sure they did. Did they do a resection or just a biopsy? No, they just did the biopsy, but they biopsied multiple of these, and these were all small cell lung mets. I think actually our urologist ended up publishing this as a case report. It's that rare to have urothelial metastases, multiple.
So it's in the kidney as well as the ureter, throughout the kidney and the ureter.
I think that it's all through the urothelium. Hold on, and you can see, right, we'll go through all the lymph. And you can kind of sort of see that the texture of the lymphadenopathy here is similar to what we see here. So I think like these are the Mets. So a lot of these are dilated calyces with like just the urothelium coated with tumor.
Right.
This was either probably a ruptured, calyx just causing a subcapsular collection, maybe hematoma, maybe also some sort of subcapsular Mets. And it's just a weird, and notice there's nothing on the other side, which is just tremendous, right? And then the bladder was fine as well. There's nothing in the bladder. So there's just a weird, just the Mets decided that they're just going to be hanging out in a urothelium on the right. All right. These are all the cases I have pulled.